John?
Greetings, everyone, and thank you for joining us today for another in the series of webinars about high-impact practices, HIPs, in family planning. My name is John Stambach, and I'm a family planning researcher at FHI 360, and I work on the topic of drug shops and pharmacies through USAID's Advancing Partners and Communities Project, APC. We have a very interesting webinar lined up for you with a variety of engaging speakers representing different organizations and geographies. First, though, I'd like to thank IBP for sponsoring this series, and in particular, Ados May for his outstanding curatorship. I'd also like to thank the entire HIP team and the HIP core partners, USAID, UNFPA, WHO, IPPF, and FP 2020. Today's HIP webinar focuses on drug shops and pharmacies as sources for family planning commodities and information. This topic seems to be of particular interest to our field recently, with lots of interest from donors like USAID and Gates, great new work by projects like Shops Plus, Evidence, and APC, and of course ongoing great work by organizations like PSI, DKT, and others. Another marker of this interest is the fact that this is the most highly subscribed webinar so far in the HIP series. Our agenda today is very simple. After a bit more introduction to the topic, we'll move right into short presentations by today's panelists. Dr. Mario Festin of WHO, Pam Riley of Apt Associates, and Fred Mubiru and Tracy Orr of FHI 360. After the presentations, there will be time for presenters to take questions, which can be submitted using your GoToWebinar link. I should note also that you can access 5 handouts through the app as well. We've included the HIP brief itself, a report based on the work from Shops Plus that Pam will describe, and 3 journal articles. Next slide, please. Before we move on, I'd like to say a few words about this HIP and the brief, which you can access online at fphighimpactpractices.org. Slide. As many of you know, family planning HIPs fall into 3 categories: enabling environment, service delivery, and social and behavior change. Next slide, please. The drug shops and pharmacy HIP falls into the service delivery category. Next slide, please. The service delivery and social and behavior change categories are further divided according to the strength of the evidence base into proven, promising, and emerging practices. Next slide, please. The drug shops and pharmacies HIP falls into the promising practice subcategory, meaning that there's good evidence that the intervention can lead to impact, but more research is needed. Next slide, please. Like all HIP briefs, the drug shops and pharmacies brief is divided into several sections. First, there's a background about the topic, and then another section with the rationale. Why is this practice important? The next section reviews the evidence base for the impact of the practice, and that's followed by actual tips from experience on how to promote and provide family planning through drug shops and pharmacies. The brief winds up with a set of priority research questions and then a very useful full bibliography. Next slide, please. I'd also like to take this opportunity to, for anyone who is interested and would be interested in joining a working group devoted to drug shops and pharmacies. It's a virtual working group with a presence on the Knowledge Gateway, but we also meet once or twice a year. So you can go to this link and join. I would encourage you to do that. Next slide, please. Moving straight into the most important part of today's webinar, the presentations by our panelists. Next slide. Our first speaker probably needs no introduction for most of you. Dr. Mario Festin is a medical officer at WHO RHR. He's based in Geneva. Many of you know him from his great work on research and guidelines on family planning and contraception. Mario is going to present the WHO perspective on family planning in drug shops and pharmacies. Take it away, Mario.
Thank you, John, and good afternoon, good morning to everybody. So the topic is on drug shops and pharmacies as venues for increasing access to contraception. I'm giving you the WHO perspective. Next, please. Next slide. As many of you know, there's this FP 2020 goal of 120 new users of modern contraceptives, and we're nearing that in 2020, in 3 years. Many factors need to ensure that, such as commodities, quality of care services, within a gender and rights perspective, and trained providers. But access is still very, very difficult, especially in hard-to-reach areas. Drug shops and pharmacies are important sources of contraceptives, and along with task-sharing programs, these can create a more rational distribution of commodities and services. Next, please. So what are drug shops? These are usually small private outlets, generally offering over-the-counter medicines and supplies, usually for common illnesses. They're very widely used sources in sub-Saharan Africa and in other regions for services, for information, and for commodities, and thus have been recognized for their potential to improve health. They've been used for not only in family planning, but for malaria, for common illnesses of children, and anything else. And these are usually handled or managed by trained community health or lay health workers and other providers as well. It's a big mix of who can provide or who could be the persons in drug shops. So the ideal mix for drug shops and pharmacies is that they could sell and administer for contraception like condoms, cycle beads, pills, injectables, and other oral contraceptives. But they can also sell and have the client be sent somewhere else for administration like implants and IUDs. Next slide, please. So drug shops, as compared to pharmacies, are more numerous. They're small, they're found everywhere, and for many people, they are the first stop for care. And they are what you would usually find in hard-to-reach and low-income areas. They do not typically employ a trained pharmacist, and thus are legally allowed only to sell non-prescription drugs and prepackaged medicines. So they usually have storefronts, a product display, and a counter. Some have examination rooms. And like pharmacies, many drug shops also sell over-the-counter family planning commodities. Next slide, please. So, but the drug shop operators should have training and have proper education, but these vary across countries. Some of them even have clinical training. For many of these drug shops, the owners or drug shop operators are typically literate and may or may not have some type of retail license, or they may or may not have family planning training or health accreditation. So the characteristics of the drug shop operators really vary. Next, please. So this slide shows what are some of the some comparisons between pharmacies, which are usually found in the urban areas, in hospitals, or in standalone centers, versus drug shops. So pharmacies have wider commodities, including prescription medicines, and are supervised by registered pharmacists. They're always privately owned and accredited. They have specifically educated and trained health personnel, primarily in urban areas, and in contrast to the drug shops, which you already described previously. Next slide, please. But drug shops and pharmacies together are very, very important sources for family planning commodities. Here you could see that they are the yellow, the orange and light orange bars, and you could see that in many areas they form a significant percentage of sources of FP commodities, ranging from as low as maybe less than 5% to as high as nearly 60%. And it also varies in terms of the modern contraceptive prevalence rate. But they are very important sources of FP commodities. Next slide, please. For example, in Uganda, there are 6,600 registered drug shops in rural and hard-to-reach areas. And they have been very successful in the integrated community case management for malaria. And they have diagnostic equipment there, they have medications, supplies. But what is important is that they are linked into the proper health system. Like the accredited district health officers provided the training. At regular intervals, a supervisor and a drug inspector visit them to assess the treatment, the provision of treatment, and of course the level of commodities availability. And referral systems were put in place just to make sure that for children who are in part of this ICCM service are referred to the proper facilities. Next slide, please. So when do we use drug shops and pharmacies? We have to integrate family planning methods into drug shops and pharmacies when there is already some high utilization and acceptability of drug shops in the community. If the health system is weak, overburdened, and unevenly distributed, as they could be other sources of services and commodities. If the government-sponsored facilities have frequent stockouts in it, and the clients find it inconvenient to keep on going there since there might be problems of distance or time that they're open, and it is also important for them to be sources that men, boys, and youth can come to because they're really just there in the communities where they live. So they would be very good if there's a high unmet need and if access to services are low because they fill in the very big gap. These are the WHO guidelines on task sharing, and we usually equate the service part of this as part of the services. So when there are drug shops and pharmacies, we do task sharing because some of those tasks that are usually provided by nurses, midwives, and doctors can be provided by pharmacists, pharmacy aid workers, or even community health workers who are part of those operating the drug shops or the pharmacies. There are the definitions there, and these are the guidelines that WHO has available. Next, please. Next slide. This is a summary table that we are going to publish soon on all the family planning methods that are available and have been undergone review in terms of who are the different providers that could provide services or give commodities. So these range from community or lay health workers to pharmacy workers and pharmacists and up to the doctors. So you could see that the green, the white arrow against the green background means it's part of the regular, they're highly recommended. The white circle with the green arrow are under specific circumstances, and the orange arrow will be under context of research. Some are really not for the to be provided in those situations, like the highly clinical requirements needed for implants, IUDs, and permanent methods. Next, please. So these are some of the policy statements policy documents that we have for task sharing and task shifting. The one on the left is our summary document, and this is presently being updated and will be available in a few weeks. Next slide, please. So what are some of the considerations when we do task sharing and using the drug shops and the pharmacies? The implementation should be shaped by specific sociocultural factors and political factors in the context in which they are taking place. The health worker availability contributes to accessibility and utilization. And the drug shop operators and the pharmacists are part of this health workforce cadre. There should be willingness within the country to consider task sharing and using these venues for providing services and counseling. And health workers should be supported by other interrelated health systems packages. And the individual recommendations should be considered as packages in terms of health worker categories and the conditions being assessed. Next slide, please. So there are some challenges and considerations. We should look at the legal, regulatory, and policy environment. We should still consider promoting quality assurance and oversight. The setup should include systems for supervision and referrals, because the competencies of providing some of the services and for detection of complications are limited for these drug shop operators and pharmacy operators. They should provide adequate product information and so that they can adequately promote family planning, uptake, and use. And there should be policy efforts to allow over-the-counter sales and provision for some of these commodities, especially like injectables and for implants, which may be given by providers who would be around in the area and would not usually be have them available to give, such as the nurses who are community nurses might not have them available with them. And we could add other family planning commodities such as the MPA sub-Q in drug shops and pharmacy, so that efforts to promote them would be wider. So we should consider drug shops and pharmacies as an integral part of the larger health system. Next slide, please. So why now? We want to improve access and availability safely and effectively. This should be part of a comprehensive access to contraception is part of a comprehensive package for SRHR for men and women. We should have policies to allow effective use of skills and competencies. And we should consider that these really are the ones that we could help those in urban slums, rural areas with high unmet need where access is poor, with health worker shortages, to have these facilities provide family planning, commodities, and services. Next slide, please. So this is our new Director General in WHO, Dr. Tedros, and he just mentioned that, and he reiterated this in the London Summit meeting yesterday, that family planning is one of the best buys that exist for global development. Next slide. And thank you. John, back to you.
Oh, thank you very much, Mario. Our next speaker is Pam Riley, who is a lawyer and is a senior digital advisor at Apt Associates. Pam works on the Shops Plus project, and today she's going to share some work done under Shops Plus that is a scan of 32 countries for looking at the legal and regulatory framework for drug shops and pharmacies. Welcome, Pam.
Thank you, John, and I'm very pleased to be here today and to share the research that Shops Plus has conducted. Shops Plus, for those of you who don't know, is a USAID project called Sustaining Health Outcomes Through the Private Sector. And the study is available in the handout as previously mentioned. Next slide. So the genesis of the study that Shops conducted came about at a consultative workshop convened by WHO and USAID in May of 2016 to consolidate knowledge in this area. And the idea is to create a snapshot of drug shop and pharmacy regulatory similarities, variations, and trends across the globe to provide some context, serve as a resource for practitioners working in particular country environments, and help to establish priorities for improving policies. While we had a particular interest and focus on family planning, the drug shop and pharmacy regulations that we documented are relevant to all health areas. And our scan covered a list of 32 low and middle income countries from 4 continents. Next slide. I'm going to skip this because Mario has already talked about the definition of drug shops. Next slide. So the scope of our research was a high-level look at the policies, statutes, and administrative rules that govern both pharmacies and drug shops. It was focused only on the retail sale of medicines, so the scan did not include the important rules related to the supply chain of the drugs themselves, such as importing, testing, registering, wholesaling. It also does not cover rules related to clinic-based pharmacies, only standalone shops. And we did not look at the issue of adequacy of enforcement. Rather, our focus was just what do the rules on paper say. Our organizing framework for the analysis was grouped under 7 headings. First, how do countries define and classify drug shops? Then rules related to the physical facilities, to the people who own or work at drug shops or pharmacies, rules that govern marketing of the shops, the proprietors or the products themselves, rules on oversight in the form of inspections or sanctions, rules for services specifically applicable to family planning, such as counseling, referrals, injections, and finally, we looked at what rules apply to the products sold, such as controls on pricing, packaging, and prescriptions. Next slide. And this slide is not meant to be digested, but rather it's just an illustration of one section of our report, which is a set of tables providing a country-by-country comparison of all the rules that we examined. We also analyzed a given rule by looking across the 32 countries at a single topic. And we did a more detailed profile of 9 countries with active drug shop programs to try and tease out trends and insights. Next slide. So I'm going to turn now to some of our key findings. I'm just going to be touching on a few in the interest of time in this webinar, but I am happy to steer you back to the report for more information. Next slide. So our first takeaway is that the regulatory framework for drug shops and pharmacies is widely varied across the globe. Some countries have not yet adopted frameworks to establish minimum requirements, and others have many restrictions. But within a given country, often we found gaps, topics not addressed, as well as activities that were prescribed in some detail. So it was very challenging to make generalizable insights as countries adopted quite individualized approaches. And it made it very difficult to place countries along a continuum from tightly to lightly regulated. That had been our plan, and we were just not able to do that. Next slide. Our second finding is that there is definitely a trend toward recognizing lower tier drug sellers in a regulatory framework, with 17 of 32 countries endorsing this lower tier of vendors. This trend, of course, reflects the critical shortage that Mario discussed of qualified pharmacists in most developing countries, and the need for a regulatory response. By sanctioning the role of lower tier drug shops, regulatory frameworks can potentially limit the illicit drug market and expand access to safe medicines. In most cases, the lower tier drug shops are authorized to sell only over-the-counter drugs that do not require prescriptions, but we did find 4 countries, Tanzania, Uganda, Liberia, and the Philippines, with rules permitting the lower tier drug shops to sell a specific list of prescription medicines from a set of common illnesses and conditions. Next slide. Our third finding is that while training requirements for pharmacists were similar in all countries where regulations were available, requiring a bachelor's degree in pharmacy from an accredited university, for drug shop personnel there was a lot of variation, reflective of different country context, as reflected in this pie chart. Training requirements ranged from apprenticeships to mandatory drug program training to medical training, or no training other than a minimum education of secondary school. Next slide. On the issue of enforcement, we found a mix of public, semi-public, and private institutions entrusted with enforcing drug shop regulations, with roughly half overseen by Ministry of Health or other government agencies, and half involving licensed pharmacists or other qualified experts in other kinds of boards, councils, or associations. Powers granted to inspectors to deal with instances of non-compliance included the ability to issue fines, revoke licenses, close stores, and in some cases, imprison offenders. Next slide. With regard to service rules, we know that these are of great importance of family planning because of the concept of informed choice. Counseling clients on safe and effective use of medicines is a basic function of pharmacists, and it's an inherent part of their role. For less qualified vendors, some with minimum or no health training, counseling raises concerns about competency and quality. And most countries are silent on this issue. We did find 7 countries requiring drug shops to provide counseling when selling contraceptives, but the others did not have any language around that. Pharmacies and drug shops in a few countries are permitted to sell injectables, the vial for the injection, and then refer women to health facilities. And to increase injectable access, 2 programs, one in Uganda and one in Bangladesh, are testing under special regulatory waivers the potential for trained drug shop personnel to provide the injections themselves. Next slide. Countries develop lists of essential medicines to promote availability that are deemed most critical for basic health needs. And the products on this list are the ones in a country prioritized for procurement, distribution, and retail sales. So we reviewed the essential medicine lists for each of the 32 countries to catalog the inclusion of specific contraceptives. And this table summarizes our findings, which shows that oral contraceptive pills were included in every country list, and the inclusion of other methods was widespread. So this really demonstrates that contraceptives have gained legitimacy and visibility in all the focus countries we looked at, which contribute to their availability at the private retail outlets. Next slide. In the interest of time, I'm going to skip to the next slide, which is some reflections on what our findings mean and where the IBP community might go from here within the context of the gaps and ambiguities we identified. Next slide. So I think our first conclusion is that within these inconsistently regulated environments with many gaps and infrequent updates of regulation, we know that the market exists in any event. The drug shops are often providing products and services whether permitted or not. So this provides an environment ripe for identifying positive practices, amassing evidence of low, manageable risks from the provision of services such as injections. So it makes sense to continue pursuing through regulatory waivers expanded roles for drug shops that can inform policy change down the road. And these pilots can provide the programmatic controls which ensure quality, gather evidence, and have support for advocacy. Next slide. A second area for exploration is in the area of enforcement. We know that regardless of the regulations on the books, enforcement is weak in many countries. They have inadequate human, financial, and technical resources. But often there are voluntary member-based organizations of druggists that can provide some oversight functions, working in partnership with the regulatory agencies or independently. And there are opportunities to strengthen these professional associations, to improve dialogue with policymakers, to better engage community voices, and to develop consensus-based ethical standards for self-regulation. Next slide, please. And an additional area for focus really needs to be the market incentives, the economic factors that shape what drug sellers as entrepreneurs do in their daily practice within any regulatory framework. And this means looking at existing or potential licensing conditions that can serve as carrots rather than sticks, such as access to credit or social insurance, or drug shop networking options that increase efficiency and revenues. Next and final slide, please. And finally, as Mario emphasized, the wide variety in minimum credentials or training requirements for drug shops suggests that this would be a fruitful area for model language as well as capacity building. In one of the consultative meetings that we conducted to validate our study findings, it was noted that we as development practitioners could do more to deepen engagement between community health workers and drug shop training resources to gain some efficiencies and synergies in working with these similar cadres. That ends my presentation. Thank you for listening.
Thank you, Pam. Our next two panelists are going to tag team their presentation. They are Tracy Orr from FHI 360. She's a Senior Technical Officer for Research Utilization and works on drug shops and pharmacies through the APC project. And also Fred Mubiru from FHI 360 in Uganda. And Fred is the project manager for APC there and is a research and evaluation specialist. So welcome, Tracy and Fred.
Good morning or good afternoon, depending on where you are. Again, my name is Tracy Orr, and I'd like to talk to you today about advocacy for policy change to permit injectables provision in drug shops in Uganda. Next slide, please. I'd first like to talk to you about why injectables are so important to provide through drug shops in Uganda, and then I will give you a history of the evidence that has been generated in Uganda before handing it over to my colleague Fred to tell you more about our specific advocacy initiative. So in Uganda, contraception use is very low. Only 35% of married women are users of modern contraception, and unmet need is very high at 28%. There are many reasons for the low use of contraception, but they focus primarily on barriers to access and stockouts of family planning supplies and a shortage of trained staff. When clients do use contraception, injectables are the most popular method and is also a very effective one. Private drug shops could offer an opportunity to expand access to family planning because they're so commonplace in rural areas, as we have heard from some of the other panelists, and they also support a sustainable commercial market for health products. Uganda has, I would say, an undisputable number of registered drug shops, as I've noted that my colleague and I have different numbers on that, but anywhere from 7,000 to 10,000 registered drug shops. Oral contraceptive pills and condoms, of course, are provided legally in these drug shops, but many do also illegally provide injectables already. As many know, several years ago, VHTs, or village health trainers in Uganda, were approved by the Ministry of Health to provide injectable contraception, and that project has been successfully scaled up. So we believe that the sale and administration of drug shops could greatly increase the country's ability to reach some of its family planning goals. Next slide. Next, I'd like to give you a little bit more background knowledge about 3 very critical local research studies which were conducted from 2007 to 2011. These 3 studies are critical in that they created the evidence base that was used for the advocacy strategy that we rely upon today. So the first study was an assessment of drug shops' suitability for sales. For sales of injectable contraception, and that was conducted from 2007 to 2008 by both FHI and Save the Children. More than 150 drug shop operators were assessed in 3 different districts, and the findings were that a majority of the drug shop operators actually had medical training. The majority of them were either nurses or nurses assistants and had also completed senior level 4 of their education. Unfortunately, we did also find that the drug shop operators' knowledge of the side effects of DMPA varied, and that training was needed on injection skills, but they did have some knowledge too of DMPA compared to other contraceptives. In 2009, based on the interest of stakeholders in the first study that was conducted, a follow-up study was put together with over 140 of the original drug shop operators that were surveyed in the first study. Again, this was conducted by FHI 360 and Save the Children. And so this was a follow-up assessment on exactly what would be the trainability of the drug shop operators, given that the previous research findings had found that there were some deficits. And as could be predicted, the demonstration study, which assessed knowledge, attitudes, and practices, did find that with training, the drug shop operators were able to safely and feasibly provide injectable contraception. Post-training, the drug shop operators' scores improved greatly from baseline on their general knowledge of contraception and method provision. The third study was conducted in 2011, and that study was an assessment of the drug shop operators' contribution to family planning service provision overall in 4 districts. Specifically, the study looked at determining exactly what was the contribution of drug shops to family planning service provision in these 4 districts as measured by couple years of protection. And so, as could be anticipated based on the data that we also have from DHS, we know that drug shop operators provided a great amount of the coverage that was provided in these districts for clients using family planning, particularly injectables. In addition, the study also took the time as well to interview clients of drug shop operators, and these interviews with clients showed that overall, they were very satisfied with the drug shop operator services. And in fact, over 95% of them said that they would actually recommend drug shop operators to a friend for family planning services. So now with that background knowledge of the local research that has been conducted, I'd like to hand it over to my colleague, Fred Mubira, who will tell us more about the advocacy process that was started since the beginning of the project, but has ramped up since the conclusion of the 3 studies. Fred?
Thank you, Tracy, for that background, and thank you, John. I'm glad to share with everyone who is listening in on the process that we've had in Uganda regarding the advocacy for the inclusion of drug shops into the continuum of FP service providing channels. So I'll start by sharing what the political environment has been like. in 2012, the government of Uganda made commitments at the London Summit, and these included, of course, funding for commodities and many other things that they thought would lead to the attainment of the goals for the country by the 2020. And following that, there was a conference held in Kampala in 2014, a national conference, which further galvanized support for family planning. And at that conference in particular, the president made positive statements to the fact that family planning was important for the realization of the country's vision 2040. And then, of course, the processes for developing the family planning costed implementation plan, which is the national strategy, 5-year strategy, had also commenced. And by then almost completely done. And this again committed the country to realize certain goals, in particular to increase contraceptive prevalence to at least 50% by 2020 and reduce unmet need by 10%. There are other, positive aspects that have happened since then, like the approval of a DMPA sub-Q scale-up plan as recent as 2017, and several other engagements by stakeholders and commitments by donors and government. In that regard, this has obviously led to some improvements in the indicators, especially if you look at the most recent DHS of 2016, where the contraceptive prevalence has increased from 26 previously to 35%, and the unmet need has also gone down from 34 to 28%. However, challenges still remain, especially in the funding commitments by government and by donors. I will now share with you what the key milestones in the advocacy process have been. We have since the gathering of the evidence that my colleague Tracy mentioned earlier, in 2014, there was stakeholder engagements that happened that led to the formation of, they led to the arrangement of a high-level policy dialogue meeting where several stakeholders listened into the evidence, discussed it, and that helped again gain further consensus towards the policy shift required to allow drug shops to administer the injectable contraception. Then following that, the Ministry of Health formed a task force which helped to review and refine the evidence. It helped to develop a justification paper, and then this justification paper has been variously presented to various organs within the Ministry of Health, in particular to the Maternal and Child Health Cluster, which is an organ that approves policy proposals before they go to the senior management. And then eventually it was presented to the senior management of the Ministry of Health and approved for presentation to the National Drug Authority, which is the authority that oversees drug administration in the country. And as recent as March 2017, the task force represented by the family planning focal person of the Ministry of Health presented to the National Drug Authority the justification paper, and it received a positive nod, but with a request that the task force goes back and develops an implementation plan which would be later presented to the National Drug Authority Board. I'm glad to share that in June 2017, as recent as last month, the plan was presented to a committee of the NDA Board for Essential Medicines, and this committee has approved the plan for at least 1 year of implementation, which will then be reviewed before scale-up. and further implementation. Next slide, please. So, of course, as the consultations with the various stakeholders ensued, there were concerns raised and fears, and and these we thought through after all the consultations and deliberations. Some you see on the screen, but there is quite a comprehensive log that we have compiled, and we've thought through the various technical areas, the risks involved, and the potential solutions when we go to full-scale implementation. Of course, things included, for instance, the fact that most of the drug shops are not licensed. As you saw earlier, the numbers are not so very discrete. No one can tell you exactly how many drug shops are licensed in the country. I think the number that we have on these slides was from the NDA for 2015. But I'm sure by now they have different numbers. So again, we committed to support the NDA in the existing accreditation processes to support that component, and then also to support the business practices and compliance. There were concerns on injection safety, and we are proposing that this can be strengthened through support supervision, through involving the districts. There were concerns that the drug shops will not report their data into the HMIS or even to the districts. And again, we are thinking of, we've proposed some quality control mechanisms, multi-sectoral monitoring, including professional associations, drug shop associations, etc. Next slide, please. I won't go through this for the interest of time. I'll move to the next slide. Yeah, so I will go to the lessons that we have learned in the process, and these, as you see on the screen, mainly the process has been multi-sectoral. It has been very consultative. It has given opportunity to the different stakeholders to raise, discuss concerns, and we tried at every point to address the ethical, emotional, intellectual concerns of the various key influencers, gatekeepers that we engaged. We've relied very much on the AFP smart approaches as we've been doing our work, having very clear and smart objectives, knowing who the key influencers are and their core concerns and interests, and being very clear about our asks at each level. I can tell you that at each level that we've been, the ask kind of changed. For instance, when we first engaged the NDA senior management, it was, our ask was that we were asking for the reclassification of injectables from Class C drugs to B so that they can be administered over the counter. And the senior management advised that that would be very complicated. It's a legal issue. It has to go through an act of parliament. And instead, we opted for the NDA board have the authorizing because they said that for that they have the authority, just to give an example. But also it has been really, it requires a lot of time, a lot of patience, concerted effort from the different stakeholders. Leveraging past achievements really helps, especially relying on the evidence that was gathered earlier, and even that from the global perspective was really helpful. I think with that, I would end my presentation there and leave room for some questions. Thank you very much.
Thank you, Fred and Tracy, for that really deep dive into the policy issues around injectable family planning in the drug shops in Uganda. There's a lot of interesting work going on in other countries in Africa looking at family planning in drug shops and pharmacies, particularly in Nigeria and also Ghana and Tanzania, and of course in Asia. There are interesting things happening in places like Bangladesh. And there's a lot more data out there now. in addition to the great scan that Shops Plus did of 32 countries, there's the FP Watch data set, and there was a great census that was done in Nigeria of over 20,000 patent medicine shops that included whether they provided family planning commodities and the type of people who staffed these shops. So there's a great deal of interesting data out there now. We're going to move on to our question and answer session, and we have a little bit of time for that. And I'd like to start with a couple of questions that we got for Dr. Mario Festin at WHO. And interestingly, they both referred to his task sharing table. And I'll let him address those. The first one was about what it might take for, I guess, injectables in drug shops and pharmacies are a restricted practice according to WHO, and that can only be provided under certain circumstances. So what would it take in terms of evidence and to bring that up to a fully recommended practice? And I'll follow up, Mario, with the second question.
Thank you, John, for the question and for the person who submitted the question. The provision of injectables in drug shops is highly dependent on who is the drug shop operator. As mentioned a few times in the presentations, drug shop operators vary in terms of background and training. Some are nurses or midwives who work in who operate drug shops in their communities. Some are lay health workers. So the recommendations for the provision of the commodity and the service is highly dependent on who are the persons who are the drug shop operators. Now, the task sharing guidelines were developed with a review of the present evidence that was required for making the recommendations. At that time, and this was 5 years ago, and it was reviewed 2 years ago, the recommendations for lay health workers, which is the, or community health workers, which is the most common person apparently who are the drug shop operators, the evidence for that was very limited. So at the time, the recommendation was conducted based on the available evidence. There were about 2 or 3 studies that could be included. But with that, the discussions during the formulation of the guidelines said that the intervention had the potential to improve equity by increasing access to family planning. So, and lay health workers, community health workers already deliver some form of contraceptive counseling and use injections. So it was suggested that that option be given in the context of targeted monitoring and evaluation. And since then, many studies are being conducted addressing this. What are the major comparative studies which would be able to assess more clearly the safety and effectiveness of distribution by community health workers of injectables. So, but generally in most of these guidelines, it's not the label or the venue where the provision, where the drugs are, where the commodities are being given, but the background and the training and the competency of the provider, whether it be a drug shop operator who is a lay health worker or a drug shop operator who is a nurse. Pharmacists vary in terms of what they can do also. So for the meantime, those are my responses.
Thank you, Mario. And the follow-up, and I'll add a comment that another participant sent in, noting that there's often an assumption that drug sellers are untrained, but the data from Uganda, as well as recent data from the big census I mentioned in Nigeria, and emerging evidence from the DRC, Congo, notes that quite a number of drug sellers actually have medical training. So in that context, the next question was, WHO allows for the possibility of provision of implants, actual implants by lay health workers, but according to the table does not allow for this possibility through drug shops or even pharmacies.
Yeah. Yes, thanks again for the question. The table is not the entire guideline. One has to go through the guideline and read what are the actual recommendations, because a lot of discussion has gone into the development of the recommendations and the guidelines. The thing is that in each country, the level of training for each of the different providers varies. So if in Uganda, they are very well trained, in Ethiopia, they have the health extension workers who are very well trained. But in other countries, the training is very minimal. It's only a 1-hour orientation, or it's an apprenticeship. You would have to really put it into the context and what would be allowed. And of course, it all depends on who is the person who is handling the drug shop for that example, because if the drug shop operator is an actual retired nurse, she could give injections very easily because that is within her established competencies. But however, if it's a lay health worker who only had a few hours of training, that would not be a proper implementation scheme.
Great, thank you, Mario. I think Tom will allow for one more question, and this was for Pam Riley at for Shops Plus. Pam, one of our participants noted that your scan didn't seem to cover an assessment of the enforcement practices in these countries, and they note how important this might be given the lack of prescription requirements in some countries, and also the very serious issue of fake medicine. Could you briefly address that?
Sure. So with regard to enforcement practices, that was outside the scope of our study because, you know, we were really just looking at what are the rules on the books, and the ability of a country to enforce the rules on the books is a much bigger undertaking, right? It's what actually happens, and there are problems with regulatory capture and corruption. There are problems with very uneven inspections and sanctions being applied. There's a lot of capacity building going on right now with regard to enforcement in the pharmaceutical space. I know in East Africa, for one. So it's just, I think, a separate issue, and it needs a lot of attention. With regard to the risks of fake drugs and what our scan might have to contribute on that, I think one of the sort of lenses that we took in thinking about recommendations was balancing benefits and risks. And we know that fake drugs are a big problem in certain areas, certain kinds of products, especially higher priced ones that are coming into the market through various channels. But we have not seen a lot of evidence about the risks of fake contraceptives and fake pills being tested and found to be a problem. So given that, the benefits of having these products available through drug shops, even if prescriptions are not accompanying the person, seems to us to be a useful way forward to increase equity and access.
Thank you very much, Pam. I think we'll try to squeeze in one quick question if I can ask Fred and Tracy to very briefly respond to this other question, which had to do with the National Drug Authority approval in Uganda. If that actually happens, Fred, what does that mean for actual programming of injectables in drug shops? And let me apologize to the others who asked questions and we didn't get to them. There were some interesting ones, and we'll have to take it up next time. But Fred, if you could respond to this one quickly, and then I'll close with, I'll do a quick closing.
Okay, thank you, John, and the person who asked. What this means is it's really big for Uganda, I would say, because it means that we are adding a new channel for family planning provision. We shall reach more rural women, especially, and maybe those in urban slums. But it means that we, like I mentioned, the NDA before the approval asked for an implementation plan, and therefore it means we shall operationalize that plan. We're going to form a task force. We've already agreed to the organizations that will be leading that. Currently it is FHI 360. And then in the plan, it includes the various organizations that would support this plan, as well as the roles of the Ministry of Health, etc. It describes the activities that will be done, the monitoring, the risk management criteria and accreditation criteria, as well as the training. Basically, that is what it means. Thank you so much.
Thank you, Fred. And again, sorry to miss questions. There was an interesting one about, we did not even delve into the very interesting topic of accreditation and accredited drug dispensing outlets, and how that might influence this entire discussion. So we'll have to look at that next time. In the meantime, let me note that this webinar will be available at this link, which and the entire webinar you'll be able to access, you'll be able to access these slides, so you can find these links. Next slide, please. And finally, for more information about the HIPs, as I mentioned before, there's fpimpactpractices.org. To join our working group, you can go through the Knowledge Gateway, and of course, other links for our other partners. Thank you very much to everyone who joined us today. I'm sorry we went over by a couple of minutes, but we just had too much great stuff to cover. We'll join us next time for the next HIP webinar. Thank you. Bye-bye.
Thank you. Bye.